All right, sorry for those on Zoom, I was muted. I just made a quick announcement. This is all in person, right, Jacaranda? All right. And just to note, this is being hosted by Global Health Midwest Chapter, so it's a great organization, and I was asked to make a special shout out to the men. Please come. It's an organization by women, but it's not for women. So I mean, it's for women and men. So the more men, the better, and the more of everybody, the better. Is what I think I'm trying to say. So please come if you can, if you'll be in town. Now, the next panel is a very exciting panel, but we also have a very exciting event happening in the middle of it. So Dr. Procy will be moderating it, and it is economic strengthening in low resource settings. We're going to shift the program a little bit. We'll have one presenter to kind of whet our appetite and get us started. Then we're all going to take our glasses and meet the rest of the WashU community outside. I heard that the eclipse is already happening, so it's partially covered. It looks like Pac-Man. Anyway, so we'll get started now. I think Matthias is pulling up the slides. And Dr. Procy, thank you.
Thank you so much, Laura. And welcome everyone from lunch. That was good. Right? You were scaring me. So as the slides come up, I'm excited to be moderating this next panel, the panel of wonderful scholars and researchers and people that I admire. So first we're going to have a presentation from Dr. Leila Ismailova. So Dr. Fred mentioned that Dr. Leila was his student. I was her student. She served on my doctoral committee at the University of Chicago. So I'm pleased to have you at the Brown School today. So Dr. Ismailova specializes in the development and adaptation of family-based interventions to improve child well-being in international context, and has been involved in international research projects in Southern Africa, in the Middle East, and the former Soviet Union. So her research agenda focuses on developing culturally congruent interventions to improve mental health functioning and reduce risk behaviors, including substance use and exposure to violence among at-risk children and youth. She integrates economic empowerment strategies in mental health prevention interventions with at-risk children and their families. So the full bio is on the website. So I just wanted to just mention that briefly. So Dr. Leila, you're welcome.
Okay, so as Laura said, this is your appetizer and the only thing standing between you and the eclipse. I got inspired by economic interventions by working with Dr. Fred on his study, SUBI. It's the one that was implemented in 2007. And he just finished his another pilot study that was SEED, right? So I think not many people even remember that one. But, and Procy at that time, I think, was managing all the, data collection and everyone who was involved in the study. And I think I learned actually a lot also from Procy. So I think it goes both ways. But while I was excited by the intervention, I also thought that I could implement it in a slightly different, with a slightly different population. And the project that I'm currently implementing, also funded by NIH, is focused on children who lived in institutions but now undergoing the deinstitutionalization program, right, and reuniting with their biological families. And why this topic? Because out of about maybe 3 to 5 million children who institutionalized worldwide, about half, about 42% actually are all from the former Soviet Union or Eastern European countries. And that is particularly strange because these are not the most populated countries. but it's because of the legacy of the Soviet system that actually had good free system of social and educational care that was providing free education, free housing, free food, right, for anyone who couldn't afford it. So it created a system when parents who couldn't actually provide for their families would place their children in institution. And in that sense, it makes the system slightly different than in the US, where a lot of kids are removed from families because of, let's say, maltreatment. In our case, this kind of group of children is often called social orphans because they do have one or both parents. They just institutionalized for socioeconomic reasons. And poverty is not the only one. Another one kind of poverty-affiliated issues could be seasonal migration. When parents go to other places to work and earn money, they would leave children in institutions hoping that at least they will get basic needs. But the problem, of course, is that for children, it creates an environment where they're separated from families, and that creates a lot of traumatic experiences, right? A lot of emotional trauma. And that was the focus of my work, right? Primarily trying to figure out how can we prevent or minimize mental health problems among kids who already have been in institutions, right? And I think, as was mentioned earlier, that now, again, all the countries realize the potential harm of being institutionalized, and then they're trying to deinstitutionalize places. These kind of efforts are strongly supported by UNICEF, and a lot of countries, in order to implement those efforts, what do? They send kids back to the same families where they came from, without addressing the reasons why these kids were institutionalized, right? So basically, without really addressing the poverty as one of the main reasons. And that's where kind of our idea for this project came. It's based on a couple of pilot work. So we are working with children of slightly different age. We're working with kids who are in primary school, 7 to 12. And because we also realize that mental health issues are very important, in addition to economic services, we actually added 2 more interventions, right? It's actually mental health care, because that's considered most commonly known approach to reduce symptoms of depression and anxiety. And we wanted to compare how that would actually work in addition to or compared to economic intervention. And we also added a 3rd intervention, which is focused on family strengthening, family communication, strengthening the relationships, helping parents and children manage their emotions. Because our main interest was to figure out, are these interventions need to be implemented together? Is it enough just to support families economically and not focus on all other things? Because once we reduce parental stress, maybe the rest will pick up, right? We don't have the answers yet because we're still in the process of follow-up data collection, but at least I will share our process of implementation. So the design that we used is called, we used the MOST approach, which is focused on comparing different components. And the 3 components that I already mentioned, and we use the standard of care is the national program, basically the main services that they would receive just from the government, right? And typically those are assessment, linkage to care services, and sometimes kind of leisure activities, sports, and etc. So we had 2 for the economic part. I will only focus on the economic. I won't cover the other 2 because I think that's the focus of our program. So we kept 2 curriculums. One was for families, for parents specifically, and that's the one that we actually adopted from Fretsi Wamala. We haven't changed much the core curriculum. It's still focused on savings, on budgeting for unexpected expenses. We slightly redesigned it and, of course, adapted it in terms of using local examples and local situations. But for children, that's where the most of the modifications happened, because since our kids are much younger age, they couldn't participate in the same curriculum as parents. So we worked with the Junior Achievement Program, and they have a program that is called More Than Money. And that one is focused on developing entrepreneurship among children. And that was interesting because in a game format, kids were learning about money, how to come up with business ideas, right? And that was a very interesting approach because when we think of mental health intervention, that's more of my area of research, right? We added economic mainly because we knew that it's important, right? But For me, I think it was also different, kind of a paradigm shift, because when we think of mental health services, we often say, okay, this is not working, this kid is depressed, this kid has low self-esteem, let's try to boost it. So in a way, we work out of deficiency system, right? We always focused on something that is not working well, and let's try to improve it. And for a child, often it already creates this a little bit inferior position. What was interesting about entrepreneurship program is that it started from saying this, like, you already have great ideas, you have great skills, let's boost it, right? So that was a very interesting approach. So for now, at least what we could say, our parents, families were able to save on average about $10. So this is roughly about 5% of their income, because most of the families in our study, they were earning about maybe, or at least receiving through benefits, about $200 per month. And what we noticed that on average, they managed to save about 300, and we had some families that saved up to almost 1,000 within a year. So you could see some pictures from the interventions that we were conducting. The little girl on the top is actually attending a community advisory board meeting that we conduct with members. Yes, exactly, with members of the different government officials. So we periodically invite families to kind of to provide their own testimonies in addition to our statistics. And it's incredible how well they behave. Like, they really listen and they pay attention. And we always kind of introduce that to our work. So I will probably end here. And I think I would be able to answer more questions during the meeting. But I think, as Lauren said, this is just to get you interested in our work.
Welcome back from the eclipse. I hope that was an amazing experience. We won't have it for another 10 years, 20. Oh my goodness. Yeah, so we made history together. So I am going to invite our next speaker, who is Dr. Larissa Jennings Mayo-Wilson. She's an associate professor at the University of North Carolina, Chapel Hill, Gilling School of Global Public Health. So Dr. Larissa, as we call her, she's a sexual and reproductive health behavior scientist with over 15 years of experience. Her research focuses on the use of economic strengthening interventions and mobile technologies to improve sexual and reproductive health, including HIV, in economically disadvantaged populations. Dr. Larissa is a director and principal investigator of the EMERGE project. EMERGE means Engaging Micro-Enterprise for Resource Generation and Health Empowerment, a micro-enterprise intervention that provides startup grants, business education, mentoring, and HIV sexual and reproductive health information text messages to US young adults engaging in sexual risk behaviors and experiencing homelessness and unemployment. She also collaborates with co-investigators and community partners on qualitative epidemiological and randomized clinical trial studies involving digital and or microeconomic behavior interventions to address HIV inequities in the US. So welcome, Dr. Larissa.
Thank you, Dr. Percy. Hi, everyone. It's such a pleasure to be here. I want to say, first of all, thank you, Dr. Fred, and to all of the iChad investigators and faculty and staff and affiliates for having me here. I'm going to talk today about addressing economic determinants of HIV in young adults in the US and Baltimore. I got involved in microeconomic interventions in the US about 10 years ago as a new assistant professor. Prior to that, I'd worked for almost a decade in many countries in Africa. And as an African American, really wanted to take a lot of the lessons and experiences that I was getting in sub-Saharan Africa to communities here in the States. So that's what I'm going to talk to you today about. So my work is actually in Baltimore. And you may ask, why Baltimore? So in the US, the HIV epidemic is largely centered in metropolitan areas. And Baltimore City at that time had the 5th highest HIV infection rate in the US compared to other cities. And of those who were newly infected with HIV or living with HIV, the majority were African Americans. This was particularly important because within the African American community, young adults aged 20 to 29 also had the highest proportions. We have kind of overlapping areas of vulnerability. And the HIV prevalence among African Americans in Baltimore was 3.2%. And we don't think of that as being relatively high compared to other settings across the world. But this was 8 times higher than the generalized epidemic definition of AIDS, and certainly something that needed to be addressed in the US. So one of my questions at the time was, why is that? What is driving HIV infection and prevalence among young Black young adults in Baltimore? And when you look at cross-sectional data, there are a lot of associations between HIV incidence and prevalence and economic measures, particularly measures of poverty. So for example, individuals in low-income neighborhoods or individuals who are experiencing unemployment or underemployment or housing instability all had higher rates of HIV. And this was certainly true in the African American community, and in particular in Baltimore. If you've ever been to Baltimore, it's about 30 miles or so from Washington, D.C. And it's an interesting city because within blocks, so that top picture there on the left shows you like row houses in the city. They've been refurbished and renovated. They're beautiful homes for families, middle income and high income families. And then just a few blocks away, there are vacant homes that have been left and abandoned. And there's a real homelessness population, a homelessness epidemic in the city. And African American youth had increasing urban homelessness in addition to HIV prevalence. And this here is just a picture of Baltimore, and you'll see that just looking at the poverty rates, the high red areas, those map on very closely to HIV prevalence in the city. So this is in 2014. I had previously done all of my work in sub-Saharan Africa, but really wanted to think about how do I start on this problem in the US? And an advisor recommended start with the literature and see what we know. So in 2014, I set out to do a systematic review just to see what kind of studies and publications there had been looking at economic empowerment trials or economic empowerment initiatives that involved Black youth. And I'll just say quickly, what I found is that in the literature of the 26 published papers at the time, only 6 of them involved Black American communities. And among the clinical trials registered with NIH, of the 16 active trials, none of them included Black Americans. Next slide, please. Oh, great. Okay, I can do it. So fast forward, I set out to get a KO1. So for those of you who are at that stage in your career, this was me about 7, 8 years ago. Dr. Fred was one of my mentors, and we wrote a proposal to do a feasibility trial in Baltimore. It's called the Emerge Project, Engaging Microenterprise for Resource Generation and Health Empowerment. We looked at the feasibility. So this is just proof of concept. We're not looking at efficacy, but we're trying to see if we can take something that's been shown to be feasible and acceptable in other countries and whether we can adapt that for a more urban setting in the States. So this intervention included entrepreneurial and small business training, coupled with HIV education, a startup grant, mentoring, and text messages around informational messaging. So our questions at this stage were just around feasibility. We wanted to know if participants would be willing to be randomized, if we could reach our target enrollment, if we experience loss to follow-up, at what stage of the process that would be, what components of the intervention would be more tolerable than others, whether our evaluation methods were feasible. So we evaluated using your traditional in-person paper-based surveys, but also we wanted to use text messages as a survey component to get weekly data. And we're also interested in unanticipated harm, so we can measure harms in the future. And so participants were randomized to 2 interventions, the experimental intervention that included all of those components I mentioned, and then the comparison intervention included job announcements on a weekly basis. So all of the youth that were enrolled in Emerge, regardless of your assignment by randomization, you were still a part of Emerge and you still received something. So this is just a quick summary of our flow chart. Really great feasibility data that we then wrote to NIH in an R1 proposal. We were able to reach our target enrollment. We were able to show that young adults in this very impoverished and difficult setting were willing to be randomized. Most of them continued through, it was a 20-week intervention. So I would say participation dropped off to around 12 to 14 weeks, which gave us insights about at the efficacy stage. And we also learned a lot about the kinds of harms that we needed to protect against. So my last slide, this is where we are now. Fast forward from writing that proposal during the pandemic, getting funding, and just starting now. The efficacy trial, our first aim is to look at the effectiveness of the intervention on economic stability as an intermediate outcome. And then later on, looking at 2 HIV-related outcomes. One is condomless sex, and one is movement along the PrEP continuum. Within Baltimore, among young adults, knowledge around PrEP and uptake around PrEP is very low. And so our hope is to move young adults from awareness to contemplation and kind of consideration and hopefully initiation if applicable. And then we proposed in aims 2 and 3, those are both mixed methods aims. We'll look at them quantitatively and qualitatively, whether there are differences in the outcome by gender and by peer support, as well as looking at some of the mediators. So that figure there on the left sort of shows that we're hypothesizing that the intervention will affect HIV outcomes through economic stability. And then the embedded mediator is that economic stability matters because we're reducing financial distress, we're increasing spending on prevention, HIV prevention, and also increasing a lot of the non-cognitive skills that are important for income generation, like grit and industriousness and kind of longevity. So that's where we are, and I think I'm right at time. Thank you.
Thank you so much, Dr. Larissa. So I am going to introduce our next speaker, Dr. Mercy Mutumba. Oh, you're going last? Okay. Dr. Mercy Mutumba is an assistant professor in the Department of Health, Behavior, and Biological Sciences at the University of Michigan School of Nursing. Dr. Mercy's work on HIV focuses primarily on adolescents with the goal of improving self-management of HIV, measurement and promotion of mental health and well-being, including the integration of mental health and HIV. Her research on sexual reproductive health focuses on understanding the individual, community, and institutional barriers to uptake of modern contraceptive methods in Sub-Saharan Africa. She has worked extensively within clinical settings in Uganda and has been involved in several projects related to building institutional capacity for health in areas related to sexual and reproductive health, mental health, and human resources for health. So Dr. Mercy, you're welcome. Okay, so as we figure out the technical piece, who would like to say anything? Oh, well, or maybe to cover that. I would like to introduce our guests who just arrived. We had challenges with travel this time around, and some of them just came in. So Timothy Opobo from AfriChild, Makerere University. We have Ms. Rebecca Walgembe, who is our training program manager, iChild Uganda. We have Ms. Sanyu Nakaita, who is our human resource. We have, we have Ms. Harriet Namboza there. Welcome. Ms. Doreen from the Minister of Health. Remember, the minister announced that one of her people was, delayed, so she's here with us. And we know Bishop is already here. Dr. Ebo is here. Oh, there, Fiona. Our own Fiona from iChild is here. Reverend Father Kato just arrived as well. He's going to be on the panel, on this panel with us. Who else? Who did I forget? Did I forget anybody? Fiona, yes, I just mentioned Fiona. Who? That's it? Okay. Welcome. Welcome. I'm glad, we are so glad you made it after long, all those challenges. For those traveling the first time, just know next time it will be much better. Yeah. I think they said A7 to 9. And that's
So thank you so much. We've overcome the technical difficulties, and I'm happy to share right now what my experience working with economic empowerment interventions. I have to start off by saying that a lot of our work is still in the implementation phase, so I don't have any exciting results to share, but I will end with some sort of thoughts on what I think, what I've learned from the field, because this is a process of learning and what I think could be done to strengthen some of this work. So I also want to share a little bit about my background, because I think that informs a lot of what I do. So I'm a nurse by training, and I started out my career working with children. So this is around really the early days of HIV. We were testing antiretroviral therapy, pediatric regimens that were just being introduced in sub-Saharan Africa. And the focus of my work at that point in time was really on adherence, because again, that was all we cared about, getting children on treatment and keeping them on treatment. So the process of getting children on treatment can be difficult, as you can imagine, especially as these are orphaned children that we're mostly working with, but keeping them on treatment can be very challenging. So today I had one of the speakers asking questions, for example, around adherence. So don't these children know, or do they have the knowledge about antiretroviral therapy? And I have to say that adolescents and children who are in care know about treatment, because every time they come to the clinic, as doctors, as nurses, counselors, that is all we talk to them about. You have to take your medications. You have to keep on medications. And if you don't take these medications, you're going to die. That is the messaging that we give them in the clinics. But we tend to ignore the social factors around these children, the challenges and the complexities of the lives that they come with. So in my work, where I started as a clinician, I was focused very much on that messaging. But then as I started going through the processes, addressing some of the challenges, the first one being disclosure of HIV. We all know in Uganda, our parents struggle with the issue of how do you tell those children that they have HIV? And we tend to wait. We delay to the extent possible. So that psychological distress that emerges after that disclosure is what really got me on the path of mental health, because I was seated in that room, constantly telling the children you have HIV. I'm negotiating with families along that process on how to get children, on how to disclose. As our children have grown, we're now dealing with young adults. problems emerge, challenges get different. They get into relationships that introduces a whole different angle. They start experimenting because they're adolescents, and just like any adolescent, they experiment with alcohol and drug use. So my path and what I'm going to share with you really reflects those sort of social transitions and dynamics of the daily experiences of adolescents and how we can really address those. So starting off, in Uganda, we know that we have over 170,000 adolescents and youth who are living with HIV. We also know that adolescents have lower rates of adherence and virus suppression compared to adults and children, and that mortality is really much higher. And this is not unique to Uganda. This is a problem in Sub-Saharan Africa. This is a global problem. This is a problem of adolescents and young and youth who are living with HIV. But the key issues for this group is really the challenges of mental health, HIV stigma, and this alcohol and drug use. Those are really the challenges and the compounding factors that we see in the clinical setting that really contribute to some of the challenges that we see in this group. So it was quite remarkable for me to really meet Dr. Fred. This was after I had completed my PhD program, and I was thinking of how am I going to really move forward with my work. I had done several studies around drug use among youth who are living with HIV in Uganda. And I was also very much interested in the experiences of adolescents who were attending school, especially the boarding schools, because being in a clinical setting, every time the adolescents came back from school, they were those that had been non-adherent. They would come back. Sometimes the caregiver comes with a whole suitcase for you to see that this child hasn't been taking their medications, or those who occasionally come back to us in the middle of the school year because they've tried to commit suicide, a very extreme form, again, as a reaction to the stigma and discrimination that is happening within the school setting. So Dr. Fred introduced me to the idea of economic empowerment. I think this is a common theme among all the sort of speakers, really to tackle that issue of poverty. Because in the setting where I had been, we had done nutritional supplementation, but how do you sustain those sort of interventions that you see are impactful for adolescents living with HIV? And moving beyond that, how do you also address this sort of social contexts where adolescents spend most of their time, the school being one of those? So we see the interventions within home settings, but the school has remained one of those areas that has been very difficult for us to get into, at least in terms of intervention and addressing issues for those adolescents who are very vulnerable. So this study, MSUBI, really is a multi-level intervention that tries to reduce stigma within, when we talk about multi-level, it's because we're targeting different contexts. So we start out at the individual level, really looking for at the adolescents, how do we address their own knowledge, their own skill sets around HIV and HIV stigma. And that is really using this both curriculum. So within the clinic setting, we do acknowledge that there are interventions that are ongoing. They receive counseling, but we also know the context where we work. Very high volume, especially when you're dealing with adolescents. Most of them are coming to the clinics during holidays. Now, as someone who sits in that clinic and you're seeing over 50, 60 adolescents on any given day, there is only so much time you can dedicate to that child. You have to prioritize. You know, you pick those who have been poorly adherent. That means that those who are going to fall through until the next time that you see them and they're not adherent, at which point in time it's a little bit too late. You want to really be able to prevent. So really tackling that issue and empowering and addressing issues at that individual level becomes very important. And that is where this curriculum that has been developed for adolescents in Uganda who are living with HIV becomes very important. So in addition to that, we tackle that with something that is really cross-cutting across SUBI studies, which are these multiple family group interventions. That is bolstered with content around HIV stigma, again, acknowledging the experiences of adolescents within these homes. We've heard from several speakers already that majority of these adolescents are orphaned. Many of them live in contexts where they may be, it's just their caregiver who knows that they have HIV. Or if the entire family knows that they have HIV, they could still be discriminated because of their HIV status. So really addressing that experience within the home that could contribute to non-adherence becomes very important. And we talk about the poverty, and that is addressed through these child development accounts. Now, the third component to this intervention is the group-based HIV stigma that I will not go into because, again, our panel is really highlighting this financial component and how are we addressing this. But again, this empowerment within the family also does filter through to the school because now the parents have the extra income that they can use to support the nutritional needs of their children who are in schools. We're also elevating their social status. You know, there's a difference between the parent who can barely pay school fees and has to really plead with the school authorities than this one who can pay the school fees and is a little bit more empowered to be able to negotiate for their child within the school setting. So you have this sort of trickle impact effects that can really elevate the experience of the child and their family within the school setting. Beyond that, I will talk about this, is really also thinking about how can we use the issue, or how can we address HIV or use economic empowerment to address issues around alcohol and drug use. And in here, again, what we are really trying to achieve is looking at the component of poverty and how does that lead to hopelessness? How do adolescents cope? Substance use is a coping mechanism for some of these adolescents or for many adolescents who are in those vulnerable positions. So economic empowerment can also be a strategy for addressing that sort of poor mental well-being, but also creating this sort of hope, optimism and hope for adolescents, giving them also something else to do. Because if they have an income generating activity, you're taking up that time that would be idle and allowing them to move forward and really overcome their alcohol and drug use challenges. So we are using this in the context of our studies, again, through combination interventions, because we acknowledge that there are other social challenges. And in here, we have a youth risk, HIV risk reduction curriculum that we are using that has been adapted from a youth livelihood skills curriculum that was developed in Uganda. In addition to that, we add a financial empowerment component under youth development accounts that help us address issues around, again, drug and alcohol use in this population. So I will use my time in the panel to really think about how else can we advance these challenges, or what sort of takeaways can we lessons that we've learned from our interventions that we can use to advance this work around economic empowerment. But these are some thoughts that I have. Perfect. Thank you.
So thank you so much, Dr. Massey. Our next speaker is Dr. Susan Whitty. Dr. Susan is a professor of social work at Columbia University School of Social Work in New York. Dr. Susan works with communities to identify best approaches to preventing HIV and other related social determinants of health. An educational background in public policy and women's studies led her to pursue social work practice and research women's sexual and reproductive health, including HIV and STIs prevention, and the many concurring related issues women experience. And Dr. Whitty's research is broadly targeted to the evolution of more efficient, effective methods for evidence-based program implementation in local and global communities. She led one of the largest HIV/STI dissemination projects to date, testing the adoption and effectiveness of a multimedia couple-based HIV prevention program delivered in HIV service agencies across New York State. Dr. Whitty has also worked since 1995 with communities of women engaged in sex work, and she collaborates with colleagues in the US and abroad, including in Uganda and in Mongolia and currently in Kazakhstan, to test the benefit of adding financial literacy, business development, and micro-saving components to HIV prevention for women engaged in commercial sex work. So welcome, Dr. Susan.
Wow. Thank you so much, everyone. It is such a pleasure to be here. I'm going to set my alarm because otherwise I will talk too long, unless Laura is going to give me a high sign in the front. Yeah, awesome. Thanks, Vajan. Okay, thank you. That'll be fine. Wow, I'm just so delighted to be here, and the amount of practice wisdom and scientific accomplishment that's in this room is overwhelming. I'm also going to start with the Dr. Fred story. So let's see, and I'm also at the age where I get nervous and forget, so I have notes. Related to actually something Dr. Layla said in reference to former Soviet countries, in 2005, Washington University and Columbia University had a joint program through the Soros Foundation that was funded due to the post-Soviet experience, bring professionals from Central Asia to do MSW training here in the United States, either at WashU or at Columbia, and then to go back to their home countries to develop civil society, to try to strengthen policies and practices using social work methods and scientific approaches to be able to address some of the complex human issues taking place. So I had been teaching for 4 years on faculty, and in came Alta Batsuk, who was a Mongolian physician. She was pregnant and due to deliver in another month. So this is my introduction to how moms globally are amazing. They will have their babies in many places and their kids will be in many other places, and they just make it happen. So I learned never ever to complain about any inconvenience that I experience in the US as a mom. But so Alta came in and she said, I lead an HIV prevention program. And again, this is 2005. And when the Soviet Union fell and the GDP was pulled out from under the country, the women were essentially locked out of financial assets and employment, during the transitioning political and economic upheaval. So many women who were very well educated essentially wound up trading sex for income. So there was a large burgeoning group of women who were sex workers, as we would define them, women engaged in sex work, and they had to make a living. And they were engaged in sex work, becoming infected with HIV because they didn't understand prevention guidance, and they were drinking alcohol and becoming alcohol dependent. So Alta wanted to develop a motivational interviewing intervention to teach women to reduce their HIV risk and to reduce their use of alcohol. And I remember we were very successful in getting NIH monies, and that was going well, and we were able to do the intervention, and we were able to reduce HIV risk and alcohol use. But I also remember the day I walked into Fred's office and sat down and said, I'm really having a crisis because I'm taking away the only coping mechanism that these women have, and that's not going to help. And he just smiled and he said, we have to do an economic empowerment intervention. And so sure enough, at the end of the study, we did a series of focus groups, and the women said, we'd really like to have alternatives. So we got to work, Dr. Fred and I and our colleague, a PhD student, Laura Cordisco-Sai, and we brought in the match savings from the ICHAD work and the SUBI work, and we brought in financial literacy because we read the literature and we realized that's where it needs to happen. And we thought about developing small businesses for this particular first project. And so that's where it all started. And so I can trace it back to WashU and to Dr. Fred. And so I'm delighted to be here to tell that story. This is just a set of acknowledgements because this work, as you know, is done by all of us. No single person does this work. And there's so many people I would thank in this room. You know who you are. This is related to something Dr. Jane said earlier, which is, this is in my office. It's an Aboriginal quote by Lila Watson. If you've come to help me, you're wasting your time. If you've come because your liberation is bound up with mine, then let us work together. And as a white Eurocentric person from the US, the only thing I have in common with many of the women who engage in sex work around the world is that I'm a cisgender woman who has some experiences with gender inequities. But otherwise, there's so many identity intersectionalities that I don't share. So I hope that my colleagues are constantly holding me accountable. And we do a lot of work, almost all of it, with community collaboration and community engagement to try to ensure that what we're doing is lifting voices instead of doing top-down global North work. And I know we still have a long way to go. This is the piece that we wrote and published last year. The research for social work practice had a special volume that they invited the social intervention group folks to publish. And so this paper actually is just what I'm going to very quickly kind of fly through and discuss. And that's 15 years of developing and conducting NIH studies that are about combination HIV and economic empowerment, or in this case, we're calling it microfinance. You're all very knowledgeable about this area of HIV. So I just want to show that, of course, people living with HIV has gone up. New infections have come down. Deaths from HIV have come down, including in LMICs, right? But Kazakhstan has a persistent, I'm talking about Central Asia today. Kazakhstan and Mongolia have low-grade persistent epidemics. In Kazakhstan, it's driven by injection drug use and drug use more generally. And in Mongolia, it's driven more often by currently men who have sex with men who are very stigmatized and very underserved because it's very dangerous to be out. And so both of these countries still have persistent epidemics. And so we still have a lot of work to do and to try to fight some of the challenges there. And this also shows down here in this on the bottom row here, Eastern Europe and Central Asia are among the few parts of the planet that still have growing numbers of people living with HIV. This includes sex workers and partners of sex workers. But of course, we're here today because the most persistent areas are in East and Southern Africa, and it's because of underservice, underfunding, and the work that's happening here is going to end the epidemic by 2030. I share Dr. Jane's optimism for that. If anyone's interested in women engaged in sex work or sex workers generally, this is an excellent volume that was written by some of the best researchers in the area, sex work, health, and human rights. And it helped me, again, remind myself to reorient to this as a human rights problem, really. At the end of the day, we're all talking about poverty, and whose humanity are we willing to lift up to end all of the challenges that we're facing? This is just a quick slide to show why economic empowerment and strengthening helps reduce what I call syndemic risk. So all of our earlier speakers talked about mental health and violence and substance use to some extent. So the lack of access to, meaning employment, job skills, education, emotional support, housing, contributes to a lack of financial resources. And that drives, for many people around the globe, engaging in sex work. And there's the potential because of that, because they're doing that for their families and dependents, increasing the number of sex acts, decreasing protective behaviors, increasing IPV or exploitation, and that increases their risk for acquiring HIV. And then under all of that is the blue line, which says economic empowerment, if we can use strengthening interventions to intervene at any of these particular points or on any of these issues, can help decrease that risk. So starting in 2007 all the way through to last year, and right now we're writing up the findings of the CHILD-GRF study, there were 4 different studies that we've engaged. This is another way to look at them. Women's wellness was the first in Mongolia, and that was the first one that I described that Dr. Alta and I did with HIV risk and motivational interviewing. Undarga, which means wellspring, added financial literacy training, business development training, vocational mentorship groups, and a conditional match savings. And so many of you are familiar with these components because of the different interventions that we've been talking about today. But that was the first demonstrated RCT that we finished that showed that match savings actually does help. It worked. The women in the treatment group were better able to reduce their income from sex work. They were more able to start small businesses and sustain some reduced risks for HIV. NOVA was a new addition that we decided to transition once we saw that the rates in Kazakhstan were increasing due to injection drug use, that we would try to orient and readapt the program in Kazakhstan. So Project NOVA kept the financial literacy training. We decided not to use business development because it's very complicated to help people develop their businesses. And we frankly didn't have enough funding to sustain that. So we used what was already provided, which was vocational training through the government. And we again used a conditional matched savings. We saw reductions in both groups for HIV risk and in income from sex work. We didn't see significant differences except for income from sex work and financial self-efficacy. So the big question that I'll continue to wrestle with, and we can talk more about, is how do we actually, what is it that we're doing methodologically that isn't necessarily showing significant differences? And I have some ideas. And then finally, the CHILD-GRF study, which we're looking at now, I'm very excited about looking at the findings because we use an unconditional match savings. And so Dr. Fred said, why are we telling women how they should use their money? Don't we trust them to make their own decisions? And of course, we'll find out. I suspect it'll work. So what we've learned is that combination HIV and economic empowerment interventions can simultaneously reduce sexual risk-taking and also violence, IPV. They are feasible and acceptable, and savings-led microfinance doesn't necessarily increase reported acts of violence, which is something that I'm personally also very happy to learn in our interventions. And finally, that findings can be adopted and adapted in many different settings. And this is just, again, an image of what is the syndemic theory of Meryl Singer, which I think gives us a future look into how we might think theoretically about bringing all of these together and community collaborations. Thank you. And one more thing is that Kazakhstan, I got your own Center for Social Development just announced that Kazakhstan launched a CDA policy recently. So the country that I was talking about is actually.
Thank you so much, Dr. Susan, and thank you to all our panelists for those excellent presentations. So I'm going to invite you to come back here for a series of questions and discussion. And as you come, I would like to introduce our last panelist who arrived, Dr. Reverend Father Joseph Kato-Bakolo, to join us as well. Reverend Kato is the parish priest of Visanje Catholic Parish located within the Masaka Diocese. And he's the former Assistant Diocese Education Secretary. In that capacity and during his, still collaborates with ICHAD, he ensured and maintained sound educational policies, standards, and procedures within the diocese. So Reverend Father Kato became involved with ICHAD from the beginning. At the parish, he housed our first research offices in Matale, and since then he has been one of the leading community partners representing the Diocese of Masaka in the communities where we work. So welcome, Dr. Joseph. I think I'm going to stay here. You want to take a seat? Yes. Okay. All right. So I have a few questions to begin with for the panel, but I'd also like to invite the audience to ask questions if you have any. So I'll ask the first question, and then I'll bring it back to you. So we have had experiences from all over. We've had from the Soviet Union, from the US, from Uganda, and also from Central Asia. And I think one of the most important things that I've seen across is that you adapting an intervention that was implemented somewhere in Uganda, and you're adapting it in different settings. So the question is not about adaptation, but because you have to work with multiple stakeholders and collaborators, I wanted us for you to talk to us a little bit about how you have engaged the community to be able to implement these interventions in the different settings. And I'll start with Dr. Leila.
So it's on, okay. So first of all, I think a good example of that the work is going well is that the community members actually are represented here. So as well, so we have Zakir Sultanov, who was the national director of SOS Children's Villages. That was actually our kind of main partner to implement this work. And because it was going so well, we actually tried to steal him and now fully devoted to our work. But our second partner is actually not a non-for-profit, but it's a governmental organization. It's under the Ministry of Health. It's a National Center for Mental Health. And I think working with representatives of these two different sectors helped us enormously in the beginning, because in some situations, actually working with the government officials, right, is easier. And sometimes it's actually easier to work with the non-governmental sector. And I think because I represented a research institutions, we needed to really navigate all these systems, right? Because getting approvals, for example, getting trust sometimes by the government was easy if you work with governmental organization. At the same time, things sometimes move much faster if you work with non-governmental organizations that have direct connections with the communities. And I think what helped me actually to get it started is really long-term relationships that existed over years. And I think that's why I think the work so Fred does, I think why it is successful, I think because of the way he treats his partners as family members, as community members. So, I mean, I keep seeing the same people, to be honest. When I entered, I was like, where's Father Cato? For me, that was the first question, because after Prosti, Father Cato was the main person that I think I kept seeing over the years. And that was, we're talking about 2007, and Father Cato hasn't changed. So I don't know what keeps him so young, but I think what I'm trying to say is that this kind of work is probably hard to do if you just come new to a new place and you just met people and let's say, let's do a project. So some of these relationships actually existed for 10, 15, 20 years, and only now they start producing some kind of fruitful relationship. So I think these three things probably that help.
Thank you, Dr. Leila. I'm going to add, and hopefully the other panelists can also include that. So thinking about economic, empowerment, talking about finances is always difficult. Bringing it up to people is always hard. But so how do you even present that component that we're going to, to do this intervention, you're going to open up accounts? So because you need a level of trust for you to be able to even do that.
And to be honest, surprisingly, trust was the most difficult part in the beginning, not because people didn't trust us so much, it's because they didn't trust financial institutions. Especially, I think Susan Weedy very well, I think explained that because of this major transitions that happened in post-Soviet countries where everything just collapsed over, like short period of time, banks could have been closed, people had money there, and then the banks just disappear. So in here, we're trying to come and say that, oh, you really need to open bank account and keep your money there. And that's in a country where sometimes, because now government puts financial, let's say, social benefits and pension into accounts, and people withdraw the next day.
Oh.
This is the level of trust people have in institutions. And now we tell them that not only you need to, have your money in the account, you need to keep it there, right? That part was the most difficult.
Yeah.
And I think, to be honest, the fact that after a while people started trusting us, it's only, to be honest, is only because of people they were working with. And it's not even just, I take no credit for this, because they really trusted the people they interacted with, people who were able to convince them, and also maybe some of people who were risk takers. So they said, okay, let me actually try it. And when most of the families were a little bit guarded, they didn't trust, and they started seeing that, this couple of moms, they decided to try, and now, within a short period of time, she has more money than me. So then other people started picking up. So I think it's really a credit people who took this risk and I think decided to engage. And people in general, I think, just couldn't believe that someone would give you money for nothing. I think that was another biggest thing. It's like just not possible.
Yeah.
I just little story, because I remember when I was applying for the Soros Fellowship that, again, Professor Susan Weedy mentioned, I was on the first year of that scholarship program. It was 2000. So there were no people who have gone through that. And I started telling my friends that there is a scholarship, I want to apply. And everyone was telling me, who is going to give you money to go somewhere? So people really didn't believe. And then you apply and things happen. So I think that's really a lot goes to risk takers.
Thank you so much.
May I say something?
Sure.
Today is a special day For some of you, you've seen an eclipse. But this year is so special to us. I just remember it's almost now 20 years since I first interacted with Dr. Fred Sewamala. By then, he was a young man. And with no gray hair.
Father Kato would like to say he's still the same.
He's still,
you know,
yeah.
he's still
But
very
coming from not belonging to our area, not belonging to our faith, so forth. He came with a new concept.
Mm.
And it was all about money. And people, we were very skeptical.
Yeah.
Especially when it comes to money. He's a new person, matching, saving. Then, in fact, that's when we took, I can say now, we took a good risk.
Yeah.
Because by then, you know, Rakai, for those who, even if at all you have never been to Rakai, but at least you read about Rakai, it was an area that was devastated by HIV. And many people by then took advantage of the vulnerable.
Yeah.
Even there were briefcase organizations promising people heaven and earth.
Mhm.
So this is a guy who came. If you save something, I will match it for your education purposes.
Yeah.
And I tell you, you've mentioned the success. I had also wanted to stress it. It's the credibility, because whatever he promised, he fulfilled.
Yeah.
That's why even the research organization has grown organically. Now, when you talk about Dr. Fred in our area, it's because of
Yeah.
the credibility. And one thing is so lucky, because I don't know, I think for us, it's the power of the Holy Spirit. He partnered with a credible institution, and that's the church.
Yeah.
We gave him entries, banking institutions, and he never let us down.
Yeah,
and you
absolutely.
guys who want to begin research or what, mind the people you partner with.
Yeah.
So that's the thing I have to say.
Thank you. Thank you, Father Kato. That was actually excellent advice. So for our trainees, faith-based organizations, and not just any, but the Catholic Church. Yes, yeah, it's a great partner. So Dr. Larissa, would you like to say something?
Yeah, thank you. That's such a great question. So I had two thoughts about that.
Mhm.
So your first question was, how do you adapt an intervention, but also engage communities
Right.
to engender their own ideas and kind of own it? So it's not top down. And I had the same dilemma because I was really inspired by Dr. Fred's work and wanted to bring that to Baltimore and to the African American community, but it couldn't just be an idea that I was arriving with.
Mm.
So one of the ways that we addressed that was through focus group discussions. We had a number of focus groups as well as individual interviews with young adults to talk about their economic experience, their frustrations with the workplace and work options or employment options in Baltimore, some of their what they call their side hustles and little gigs, things that they were proud about in terms of income generation that they were leading and their passions. And that discussion actually led us back to what Dr. Fred was doing in Uganda in terms of entrepreneurship and thinking about savings and thinking about applying that to address economic vulnerability. So I think that initial engagement, we published those papers. The community organizations that we partnered with were co-authors on those publications. We were able to use that documented discussion to apply for and receive funding. And then the second thing that I think was really important, I mentioned in our talk that for Emerge, you're randomized to one of two interventions. Because in our setting, being in a research study and being randomized to nothing or randomized to usual care is very difficult. People want to receive something. And so having our community partners, we are essentially what they call a wraparound service. So We are sustainable in the sense that we're a part of these NGOs. They offer a number of services like emergency housing, psychosocial counseling, some job placement, things like that. They call them wraparound services for youth who experience trauma. And so Emerge is one of those wraparound services. So even though we're randomizing within Emerge, if you're randomized to the experimental intervention or just the comparison intervention, you're still a part of the community setting. And I think that has contributed to it feeling more engaged and more like a collaboration with the community, even though it's research.
Thank you so much. Dr. Massey and then Dr. Susan.
Yeah, thank you. So for me, I reflect along sort of on your questions. I think about how we got started in the field. Because again, I was lucky in the sense that MSUBI has been running in Masaka or SUBI studies for a really long time. And as Dr. Falakato has said, iChad has a lot of credibility in the area. But even in that context, one of the things that I remember was this sort of community consultative meetings when we did. Some of them we went along with Dr. Fred to really listen to the community members, to explain to them what we were trying to do and get that feedback and that guidance and the buy-in, because we were expanding into several clinics. Some had the history of working with iChad and could understand sort of what we were trying to do. But for the new one, there's sort of that skepticism that you're getting from them, and really being able to help them understand what you're trying to accomplish, but also listen to their challenges. You know, oftentimes we have our plans. So like we are planning, for example, to randomize. That is not something communities like, because for them, what is the equity, you know? So what happens, for example, to the groups that are going to be in the control condition? How are you going to address their concerns? And they also share the other challenges that they feel that they have in working with these populations that I think are valid concerns that you want to take into consideration. So that sort of community listening, being able to see you, coming down to them, just the PI and your, for many people, it almost seems like we are in another world. So you coming to them, talking to them and explaining to them, and they see that you really want their buy-in, I think builds that trust. And I thought that was very important.
Thank you. Thank you so much. Dr. Susan.
Thanks. I have only a little bit to add. I think these are all, this is amazing wisdom up here. It's all about relationship, right? Everything that we do, and as social workers and public health folks, I think we know that it's about trust, it's about building relationships over time. Before we knew well to make sure that we were doing everything from the ground up with community narratives, we would partner with NGOs, and that would be where we'd start. And we were always sure to go to the agencies where we would find participants for our studies. But over this last 15 to 20 years that this work is happening, implementation science has also evolved and taught us that we must begin with the end in mind, right? So we must begin speaking to the people that we intend for any of the work to influence. And so it has to be strongly community engaged, and pretty much every single decision should be made with community engagement and communities in mind. So all that you are, all of my panelist colleagues are talking about is essential. And so all of our junior investigators out there, start building your relationships and start bringing your communities together. We also, at least in my shop, we've never had an absolute control. We've always had something that we're offering to the community. And now we should be asking the community what would be an appropriate control if we had one. What would that look like? And how would we make sure that everyone's engaged? And it's always true that your reputation builds, right? So you are your reputation, and we have to start as leaders of our research groups and colleagues in making sure that we're holding each other accountable and that we're making sure that we're always responsive to what the community needs.
Thank you so much, Dr. Susan. So is it 3:30? Okay. So thank you for those contributions. So I'm going to give a chance to our audience to ask questions, because Dr. Mpang.
Thank you very much. All these are very good strategies addressing the determinants, economic strengthening, economic empowerment. They are all very good. And this question is cut across. When you're using multiple interventions, it might be quite hard to know which of those multiple interventions was more effective. So did you consider that in the modeling? And secondly, as we do research, we think about sustainability. So did you factor in a component of health economics, costing, so that this could help inform policy, so that somebody is able to know that if government wants to take over this, it could have this input? And thirdly, did you think about how this impacts on the quality of life, like focusing on the daily adjusted life years, quality of life? And also, did you think about the short versus long term after this intervention? Will this be sustainable for, is it 5 years, is it 10 years? Do people become fully empowered and outgrow and going to empower others? So I'm just wondering how those could be considered as this work is done, or how they were considered. Thank you very much.
Wow, where do I go? I'll give opportunity to the two trainees.
Okay, thank you very much for the great presentation. Mine is more of a comment, but addressed to Mercy. I don't know how these savings groups are organized, but in Uganda, we have the circles. Yes, and I don't know whether it's possible for them to benefit from the PDM model. PDM is parish development model. Right now, government is putting money into these circles. So since we've been talking about sustainability right from the beginning in the morning, I think this is one of the way that sustainability can be achieved in as far as the saving groups are concerned. Thank you.
Right. And the last question, yeah.
Thank you very much, ladies and father, for the interesting work you're doing. My question, it has been a long journey from where you started, I think over 20 years when this economic empowerment is being done. Are there instances where someone has tried to use economic empowerment that is not necessarily cash? I know you've talked about vocationals and all that, but I mean like giving someone or a group a sewing machine, or giving them a pickup to transport their items, or giving them even a cow for milking, or a group of chickens. Does that work as well as the cash projects?
Thank you. Would like to begin?
I can
Okay.
answer the first question because the answers are brief, whether, we use the design that allows you to test for the combination of different interventions. Yes, and I think that's why I presented most design, right? That uses fractional factorial approach, which we already know that economic intervention works. We know that mental health interventions work. We know family strengthening works. The question is, do we need to implement all of them? Are some of them necessary? Are some of them just an add-on that is optional? So these are the questions that could be answered through this fractional factorial design, because it could use smaller sample size of people, but create multiple different groups. Let's say mental health plus economic, or economic and family strengthening, right? So different, or mental health alone. So that's first question. And in terms of sustainability, it's a big concern for us because, again, it's a new project. So for us, we only last for 2 years, and lots of families are asking that we want to continue saving, right? But at least beyond this project, we don't have any other options for now, at least.
Thank you.
And I can just respond briefly to your last question about other types of economic empowerment besides cash. So for example, I know Dr. Nancy Glass, who's at Johns Hopkins School of Nursing, does a lot of work with colleagues in the Congo through animal husbandry. So instead of giving cash, they give rabbits and pigs to adolescents who they essentially become the lead of an animal husbandry program for income generation for their families. within the Baltimore context. So one of the challenges, I think, of doing economic strengthening interventions in the US through NIH funding is the economy of scale. To really start a business in the US, you need well over per participant what an R01 NIH grant can manage. And so one of the critical reasons why we added mentoring and asking our mentors to provide apprenticeships and internships is so that our participants can receive that kind of economic empowerment through relationships, and that mentoring relationships, so we pair them with a self-employed business owner in Baltimore, and we try to target a diverse sample of business owners based on the participants' occupational area of interest. So if they're interested in cosmetology or medicine or food, we pair them with a mentor in that area. And that relationship is intended to go beyond the active funding phase. And then the training that we provide as well. Most of the participants, if not all of them, none of them have been to a business school or had any kind of income generating training in high school or college. It's not a part of the public education system here in the US. So we're very much focused on this notion that economic empowerment is certainly important to have cash, but there are other elements of empowerment that are important to integrate. Thank you.
I think with iChat, EBA has been involved directly. We have IGA trainings, then financial literacy. It moved from students to even their caregivers, caretakers. And this mentality has grown up. I just remember one of the beneficiaries told me that, thanked me for having maybe brought Dr. Sawamala to the area. He told me, now I no longer ask my children to give me money. I just tell them, you buy a sack of fertilizer, organic fertilizer. You would have, if it costs 150, but if you give me one, it means you have given me 450 shillings. So already that mentality is spreading organically. I cannot say organically. Yeah, organically, even to the caregivers. So it's something. And the able with ICHA did a lot of, and parents were also sensitized. Children took care of their goats, their hens, chicken, just to sell so as to be their money to be matched.
Yeah.
I think.
Thank you so much, Father Kato. So unfortunately, this part I felt like it was just beginning, but we are out of time. And so I would like to say thank you so much to our panelists. Please reach out to them, go talk to them. They are all easy people to talk to. So if you have a question specifically for one of the panelists, please go talk to them. So we have, in 5 minutes, we'll be taking a break, a coffee break.
All right. Thank you so much. Sorry for just kind of coordinating some moving parts. 5-minute break. Our next session was supposed to start a couple minutes ago, but if we can do a quick bio break and get some tea, refresh your cups. 5 more minutes. We'll see you back in 5. Thank you.
So for our next part of the program, we are going to, before our next speaker, we are going to invite to give a few remarks, and I'll invite Father Kato to introduce the bishop. Father Kato. Observing protocol.
As I said before, that this is a special day, and indeed it is. May I take this time to introduce to you my Lord the Bishop, Bishop Severus Jumba, the Bishop of Masaka Diocese. And when we talk of Masaka Diocese, it comprises of over 5 political districts. And within the people is leading, we have institutions, leaving aside the people. Like in Masaka, we have over 400 primary schools. We have over 60 secondary schools and other tertiary institutions. And what is special about the schools or the institutions is leading, our schools even recruit students regardless of their religious affiliation. Yeah. And is very passionate about education. He just succeeded 5 years ago, the late Bishop Kagwa, John Baptist, and now is taking over the work vehemently. Is it vehemently? Seriously. So, my Lord, I'm very delighted. And you are working very closely with Dr. Fred. And thank you for coming to St. Louis. So, may I invite you to address the audience? Thank you.
Good evening to everybody. I know you will time me. I don't know how much time you have given. Yes. Chicago. It was a nice experience. Thank you. Profish, thank you. Father Kato, thank you for introducing me. My name is Severus Jumba. It's a Latin name. Actually, it's the root of the word severe. There was a Roman king who was very strict, and he had that name, but there was also a bishop who was a saint from Ireland, and he served in Italy. So I'm named after that one. And I come from a family. My mother gave birth to 10 children, and I am the 8th. After me, there follows 2 girls. We are 4 boys, and we were 4 boys. We have lost one. He has been called to the Lord, and 4 girls are also survived by my mother. She lived to a mature age. She died in 2021 at 95 years of age. And I was very happy because she was still sound, mentally, physically. She could carry herself around. And I was born in 1962, ordained a priest in 1992, ordained a bishop in 2029. So I'm now, this year, 34 years priest. Sorry, 32 years a priest, and I'll be 5 years a bishop. I came here with Dr. Ebo. We have struggled together to arrive. And I won't tell you he's a fighter. He was crashing doors, and we thank Bethel for following up. I thank everybody who has made this conference happen. And I thank you all, the participants, for the active participation I've witnessed so far. It's amazing. You all seem to put your all in it. And the presenters, brilliant. I am also a teacher by profession of high school level. I used to teach Latin mathematics, and business studies, specifically principles of accounts. And I've been in my ministry as a priest, formator of seminarians. I've never been a parish priest. I've been a treasurer of the diocese. I've been shortly for 4 years a vicar general. Vicar general means assistant to a bishop. And unfortunately, the same who made me his vicar general is the one I succeeded, but he passed on during COVID crisis. I'm very happy to carry on the work he started with Dr. Sewamala, Fred, and all the other team leaders, team players. And I think it's very important as we are talking, somebody asked the question of sustainability. We need to work with structures that are resilient, that pass the test of time. And it's not our own making, and the church is such. As Father Kato was mentioning, we have social strata within it. Like in my diocese, we have the family, we have groups of families we call base Christian communities. We have families which make a sub-parish. We have sub-parishes which make up a parish, and we have 64 parishes that make up our diocese. Political districts are not just 5, Father Gato, you have forgotten, they are 9, plus now the city, making them 10 local government units. Primary schools are 449, founded by the church. Some are assisted by government. They pay some of the salaries for the teachers. The rest are primarily run by the diocese. We have 69 high schools founded by the church. We have now 16 vocational technical schools. And when we come to health, we have 2 hospitals. They are small, considering the size of hospital you talk of in developed countries in the West, in America and Europe, and 36 low-level units. So when Dr. Sewamala comes to the diocese, he works under that social strata, and it's important that we disseminate the information after your research, and it goes back in those structures. I'm happy to report that that information really does come back to us. I want to be particular. I'm very passionate about the family unit. So last church year, 22-23, we had a theme, let us strengthen the family, based at those units I mentioned, the base Christian communities. And then by providence, or by coincidence, even though you don't believe in a God, by providence, you started a research, Amaka, Amasanyu, in our local language, meaning a happy family. And I requested the chairpersons of the family groupings in each parishes, which is usually a married woman and a married man, not couple. They choose from among the married men and from among the married women in a parish, and those to become the chairpersons of the married couples. And when this information came back to them, it was very, very beneficial, according to what they reported to me. They were actually invited Somebody asked before I came, how do you give back the information, the findings? These people came, the information was shared with them, they asked questions, and now it's to us to take action out of the findings. That's very, very beneficial. My humble advice to the present topic, how do we empower, how do we bring the sectors together as we do the research to empower the children? I would suggest, and even you have mentioned the women, Doctor mentioned the women who had been sex workers and they were being encouraged to take on a job. In our African situation, in the Uganda situation, to be particular in the Masaka situation, I think you have also to work on the mentality or attitude towards work, worker ethos, such that people learn to be hardworking. Everybody who talks about Professor Fred mentions that is very hardworking. Yeah, that is lacking in most of our African setting, African communities. They kind of want to be given, but if you are given a startup and you don't work hard, it cannot be multiplied. It becomes very difficult to sustain what you have received. I request you that that attitude is cultivated in the children we are working with. Father Kato mentioned them, but also in the other supportive people who support our activities, the caretakers, the guardians, the judges, grandparents, and the relatives. Many times it's an extended family member who takes care of the orphan or the victim of HIV/AIDS. Thank you for this effort. Keep working on it. I offer my support wholeheartedly.
Thank you so much, Bishop, for those remarks and for your words of encouragement. We appreciate you. So our next, I have the privilege of introducing our next speaker, who is also my colleague here at the Brown School, Dr. Trish Cole. So Dr. Cole's scholarship, which draws upon several years of clinical social work practice with children and parents in low-resource communities, is focused on developing, testing, and implementation of interventions to promote the emotional development of young children, treat early childhood emotional and behavior problems, and prevent child maltreatment. With a particular focus on families facing adversity, she has carried out this work with diverse populations within within a broad range of services, locally, but nationally and globally. She has received substantial funding from the National Institutes of Health, the Centers for Disease Control, and as well as private foundations. Dr. Coles holds a joint appointment as a research director of the Human Center for Child and Family Development in the Division of Child and Adolescent Psychiatry at Washington University Medical School. And the aim of this center is to advance the science on early childhood mental health to improve child and family outcomes prenatally through age 7. So welcome, Trish.
Thank you. I appreciate that, and I appreciate the opportunity to talk with you today about my work in Haiti. Here we go. So today I'm going to actually talk to you about some work that Dr. Laura Iannati and I do in Haiti that is funded by the NICHD. It was also funded, we got a small amount from the Institute for Public Health here, and from that we were able to leverage in RO1, which is really exciting. I also want to say I do have some work in Haiti in which we collaborate with Catholic Relief Services that I'm not going to talk about that today, but that's some work that I'm really proud of that we're doing as well. So thinking about poverty and child outcomes, and I know that you've talked about this throughout the course. And oh, by the way, I'm also going to focus us on young kids and mothers. You know, worldwide, approximately 365 million children live in extreme poverty, and this is prior to the COVID-19 pandemic, and we know that that number has increased since then. And there is then a disturbingly high number of children around the world with stunted growth and development with that has consequences across the lifespan. So there is it's really important that we intervene early in order to disrupt those trajectories. And there's been improvement with stunting, which is wonderful. However, there are still way too many kids globally that experience stunting and poor child development outcomes. And so there are estimations that 21.3% of children under the age of 5 still experience stunted growth. And there's a relationship between stunted growth and other outcomes as well. There's increased risk of infection, susceptibility to chronic diseases, cognitive impairments, and poor behavioral health outcomes across the lifespan. And then the long-term impacts. And I'm going to, recognizing time, I'm just going to hurry through this. We know that there are long-term outcomes, hence the need to intervene early in order to get better outcomes for kids and families. And so here I want to start talking. I'll talk about how this work in Haiti evolved. So my colleague Laura Iannotti had been doing research on child nutrition in Haiti for many, many years. And our offices were across the hall from each other. And she was had a degree in public health. I had a degree in social work. My work focused on early child development, social emotional development, intervening with parents to support them as they helped their kids reach their full developmental potential. And so we, those water cooler conversations, we talked a lot. And then we're like, okay, we have some data. She had some data, so let's collaborate. And then she's like, okay, Trish, you have to come to Haiti with me. And once I went to Haiti, we've been working together in Haiti now for 10 years. Trying to disrupt these long-term impacts, because we know parenting in adversity, parenting in extreme poverty is really, really challenging. So how do we best support particularly mothers? I will say our focus is predominantly on mothers, but we do have a few fathers that really want to come and we don't turn them away. So we've let them participate as well. So there's multiple mechanisms then through which poverty disrupts early child development. And that's biological. So through inadequate nutrition, through infection, through environmental factors, exposures to toxins in the environment, poor hygiene and sanitation, as well as psychosocial, so that responsive parenting, or actually non-responsive parenting, is associated with adverse outcomes. And responsive parenting is that meeting the needs of the young child in a good enough way. It's never perfect, but in a good enough way. And then how the need for early learning environments, for cognitive stimulation within the environment, and all of these things when the adverse outcome is present, it actually impacts neurological development. And we know there's a more and more research over the last few decades on neuroscience that has shown us the impact of adversity on children's brain development having long-term consequences. So one of the pathways is malnutrition. And so in early childhood development, particularly on the global stage, much of that has been around nutrition and intervening to improve early childhood as well as childhood nutrition, trying to disrupt those grave impacts of poor nutrition. Because malnutrition in different forms, micronutrient deficiencies, and can contribute immensely to the global burden of disease and disabilities. And so intervention around early nutrition is absolutely critical. So looking at that optimal feeding period. So we're actually intervening during the complementary feeding period. So as mothers who mostly were breastfeeding are introducing foods into their child's diet. So kids enter our studies typically around 6 to 8 months, sometimes a tiny bit earlier, sometimes a tiny bit later than that. But we know that that makes a difference in cognitive, social, and motor development. There's also a need for a diverse diet. Oftentimes in Haiti, the most common, we know from the work we've done with our CRS study, is that it's typically the introduction of porridge. What we're striving to do is increase the introduction of animal source foods that have both the micro and macronutrients that kids need for early brain development, for early growth, for better growth and better development. Because we know without those things, there are deficits in both DHA and choline. And DHA is an omega-3 fatty acid that is related to brain development, and choline has an impact on memory, has an impact on mood. And these are both found in eggs. I know a lot of people don't like the yolks of eggs, but that's actually the DHA is found in the yolks of eggs. So I encourage all of us to eat our yolks. I'm just saying. So we want to introduce this animal source food, and eggs are, as I said, an optimal option because of the DHA and the choline. And so Dr. Iannotti has done some work both in Ecuador, in Malawi, that has tested an egg a day for 6 months only. That was the nutrition intervention, and they got really, really good outcomes across a lot of biomarkers, including DHA and choline, as well as the increased average length for age, Z-scores. So it was really, really exciting. But one of the things that wasn't looked at or wasn't tested was that social and emotional development that we know is also so important. I'll tell a story here in that. So the first time I went to Haiti, had the opportunity to meet several parents, but there were several mothers and their babies, and there were two that really have stayed with me immensely. And one was a mom that held her 18-month-old, that we talked with her for about a half an hour, and she held her 18-month-old baby the entire time. He clearly was malnourished. You could tell from his hair, you could tell from his face, and she never looked at him. She never touched his cheek. She never engaged with him for that entire half hour. Another one of the mothers we met with and talked to for about a half an hour, the entire time, she stroked her baby's cheek. He was 18 months and he also looked malnourished. And Mama smiled at him. He played, his little brother was playing with him. He was so engaged. Mom was so engaged. And, you know, the outcomes, we know the outcomes for the engaged family are going to be better than the other family. And that first mama, have no doubt that she was depressed. And so a piece of the work that we're doing is looking at the impact of depression. I'll talk some about that, of mom's depression, because that matters. And so how are we intervening to support mom's distress as well, so that she's able to be there? Back to the science. One of the things we know is that what I was talking about, that there's these dual pathways. So you have the nutritional pathway, that food insecurity actually impacts young kids. And that's related to the quantity and quality of food, the types of food, the availability of food. But there's another way, and that's through the caregiver's stress, that's characterized by depression and anxiety. Can be related to the lack of food, the lack of housing, so many stressors that families are contending with that impact their ability to meet the needs of their kids. And then we move to water quality and sanitation and hygiene. We know that poor water quality, poor sanitation, poor hygiene is correlated with malnutrition and diarrhea, infectious disease, and that kids living in unsanitary conditions are more likely to have these exposures and to have these infections, and that the infections themselves lead to nutrient loss. And so there's malabsorption of those nutrients. So the body doesn't absorb the nutrients that the child is able to take in, which in fact leads to then impaired development, and including stunting. And then we have responsive parenting. So that's that third tier, that social emotional tier. And that's the caregiver's awareness and response to the emotional needs of their child. We know that when parents, and this is again, that good enough, when they are able to respond, kids are going to have better developmental outcomes. And we talk about, and there's some research around providing early learning environments, preschool, kindergarten, but the home is also their first early learning environment. So how do we ensure that where parents are creating that environment where the child has the opportunity to interact and engage with things around them? Because we know that increases their language, it increases their cognition, and that relationship. Kids develop in relation to others, so that back and forth between mama and baby, or grandma and baby, or aunt and baby is so absolutely critical, and has an impact on brain development. There is some research in my colleague, Joan Luby, who is in psychiatry and I work closely with, has demonstrated that non-responsive parenting is actually associated with a smaller hippocampus, as is malnutrition. And so there are direct causes that neuroscience is allowing us, and imaging is allowing us to actually look at and study. Conversely, responsive parenting is associated with better brain, cognitive, language, and social development, and can actually buffer the effects of early adverse exposures like poverty. So that's absolutely critical. And we know, so that parent that demonstrates responsive parenting has a buffering effect between that adversity and poor outcomes. So what we know, there's been a whole lot of neuroscience telling us about the developing brain. We know that young brains are susceptible to adverse experiences, and that adversity in early childhood can set a life course of poor outcomes for kids. And we also know that that parent-child relationship can optimize brain development. And so we need these early interventions that include parent-child relationships. Also need to include malnutrition, need to include nutrition, need to include WASH, but we also need, how do we help families create home environments in which they're getting the stimulation that they need? So what has historically happened is that we've had siloed interventions, that there's been WASH, there's been nutrition, and there's been early learning or responsive parenting. And they have an impact. They have had an impact. But there's a growing literature around integrated interventions that simultaneously target all three, that have been shown to have a more powerful, a more robust impact, and that also impact social and emotional development, which the other two don't. So for our Grande BN study, we are targeting all three of those that I've talked about: the psychosocial, the biological, and the environmental, to disrupt the path from extreme poverty to growth and development. And we're doing it in Haiti. And we're doing it in the northeast of Haiti, I will say, in Cap-Haïtien, not in Port-au-Prince. But an estimated 60% of Haitians live in poverty. 24% live in abject poverty. Food insecurity affects half of Haiti's population. There's a large number of children with stunted growth, which is highest among kids 6 to 11 years old. And I will say, in currently, even though most of the unrest is in Port-au-Prince and the surrounding areas, it is having a strong, it's impacting all of Haiti. There are supply chain disruptions, that food can't get in. There is gang violence. We were there in November, and there were roadblocks frequently that we would be asked to pay to get around, or we'd have to drive 2 or 3 hours out of the way. And it's gotten worse since November. So I will say, though, we have an amazing team, and I'll talk more about that as we go on. But we did, with the IPH data, or that IPH money, our $15,000, we went and we pulled it together with some other money. I will say it wasn't just $15,000, because we did really do a lot with it. But we conducted interviews, we conducted focus groups with parents as well as with community health workers around interventions, around what kind of information are they missing? What do they want to know? How do they want to receive that information? Are they currently receiving anything around responsive parenting and child development through the community health workers? And they weren't, and they wanted a group-based, they didn't want it home-based, but we spent time with them, and then we came back and we're like, okay, let's develop an intervention. And I said, let's first look to see what's out there. And we found an intervention that Daisy Singla, who was at McGill and is now at University of Toronto, had developed, and they had pilot tested it actually in Uganda, and got good results. And we reached out and were given permission to adapt it for the Haiti context. And so there's 12 sessions in this. And so then also before we did we have the large study, we actually did a small pilot. We did a small pilot, 15, we randomized 15 into the intervention group, 15 into the comparison group. So it was small, but remember, we had $15,000. So, and we pilot tested the intervention that covers hygiene, food, play, conversation, and self-care. Remember that mom's distress has a strong impact. So how do we also introduce ways for mom to feel supported, to be supported, to take care of herself? And then all five. So as each week has a specific topic, but all five of those are reinforced every week. How stressors impact child development, taking care of moms, taking care of your moms taking care of themselves, creating that stimulating environment. And so we bring things that they can find in their household. How do you make toys from things that are in the household? It's really difficult to find toys that are appropriate for early childhood. We have looked and looked and looked in Haiti for things like rattles and things that aren't choke hazards, but we can make them. So we show them in the groups how to make those. New ways. There's not a lot of books. It's hard to find books, but you can talk to your mom. Or moms can talk to their babies. They can sing with their babies. They can dance with their babies. And they do that. They bring their babies and they do that in the group, in the class. And how to prepare different animal source foods. So we're giving them, I'll get to this in a minute. We are in the current study, we actually give them an egg a day for 6 months as well. And so they're taught lots of different ways to cook the egg. It covers wash categories, talks about family relations and positive communication and problem-solving skills, and then making play more challenging for young kids, and then the storytelling and engaging. And then there's a review session. So it's 12 weeks. And I'll talk about the pilot and then I'll talk about where we currently are. So what we found in our small little pilot that was really grounded in implementation science, we were looking at feasibility, acceptability, and appropriateness of the intervention. And in terms of feasibility, we demonstrated that we could implement the study in partnership with a community health clinic, Fort Saint Michel. We established the partnership for a larger trial. We demonstrated that we were able to recruit and retain parents, even though it was small, we could recruit them, and that the measures were culturally relevant. So we were able, that our adaptations that we had made to our measures were appropriate. And so then for the R01 we currently have now, Fort Saint Michel, we pay them rent and they give us an office space. And then we're able to hold the group activities in a larger group room there. So, and we support them in so many ways. And because they are, by allowing us to be in their space, they are allowing us to do this study. And I also will say that the relationship with Fort Saint Michel and Dr. Iannotti has gone beyond the 10 years. She's been working with them for like 15 or 20 years. So there was receptivity to the intervention. Mothers talked a lot about, they learned about what foods they should be giving. They learned about the importance of play. And that this was the first type of training. And they really liked that things were explained and then it was demonstrated. So that interactive piece, they aren't just being talked at, but they're being engaged with. And so in learning, but however, they wanted it longer. They would like to have continued it. But it wasn't, some others talked about add more diversity. You've talked to us about food diversity and you're only giving us eggs. So they did, really good point there. I will say, and they really want how when this goes away though, can we continue and that sustainability and so in the R01 we're working to identify some strategies on how it can in fact be sustained. One of our major partners though is the Ministry of Health, so that is good. We work closely with the Director of Nutrition. And she is very interested in looking at ways we can sustain. And so we are looking at that. How am I on time? Okay. Oh, are you sure? Okay. So appropriateness then, there are some behaviors a mother must do. I did not know them. I now know a lot of things and I better understand what child development means. They talked about the animal source foods and they talked a lot, and this is just one quote, but it wasn't common knowledge around talking to your baby. Babies don't talk back. They don't. So I didn't know that. I need to talk to my baby from the very beginning, from birth. And so most of the mothers actually talked about how important that learning was for them and the impact that it had, because they saw changes in their children. And I do a lot of mixed methods now, even my large trials. In addition to having all of the quantitative measures, I often will have qualitative, because I want to, how did they perceive the change? That's really, really important. And they saw change within their kids. But a couple moms didn't see change, and can understand that. And in this quote, so I didn't really see the difference, because when someone lives in a difficult situation, it is very difficult to take care of the children. And I think that encapsulates what we're trying to do. How do we make it easier, given really difficult situations? So we do now have an R01 that is in the field. Looking at first and foremost, so we have 3 arms. We do have the well baby care. However, at the end of the study, well baby care gets a mini intervention. We have egg a day only, 1 egg a day a month for 6 months only. And then we have 1 egg a day plus the Grande Bien intervention. And so what that second condition is allowing us to do is replicate the work that was done in Ecuador and Malawi, as well as add to, they haven't tested the social and emotional development as an outcome of nutrition only. And so this is allowing us to look at those outcomes. We are then looking at the impact of Grande Bien plus an egg a day. We do have an economic aim in there to look at the costing analysis of this. Are the impacts great enough to cover the additional cost associated with it? And it's also allowing us to explore the interactions and the relationships between the biological, the parenting, the social emotional, as well as the wash. And we have, in addition, we have a lot of measures, and I'm really grateful for that. In addition to food diaries that are done, a 24-hour recall that started out being done once a week. We had to move it to once every other week because transportation is pretty difficult right now. So we also we're drawing blood at 3 time points from the child. So we will be able to look at those micro and macro markers, the nutrition markers. We have measures of responsive parenting, of maternal mental health, of cognitive stimulation, and then environmental factors. And we do actually, for a subsample, we have reports around diarrhea, the mother's reports of the child experiencing diarrhea. And then for a subsample, we actually have stool samples that we'll be able to look at. So in addition to testing the outcomes, we're going to be able to test these different relationships, which I'm also really excited about. And I'm going to, we currently have 480 dyads. I was hoping that I'd have some preliminary data for you, but I don't. I apologize. We're still working on it, and students are defending their dissertation. Yeah. So anyway, and we do have data at baseline 3 months, 9 months, and 12 months. So I hope soon to have great outcomes for you all. And I know I went longer than I should have, but I'd love any questions. Yes.
Thank you for sharing that. That was wonderful.
Thank you.
I just had a question with regards to the eggs. I really marveled about how simple the intervention is, and yet how beneficial it is for nutrition and growth. In Haiti, how difficult or easy is it to get eggs? Is it like St. Louis, where you can kind of walk down the road, or is it something that's more involved for families?
So it is more difficult now than it was when we started. We started pre sort of political unrest, and worked very closely with a producer. We went to their farm. We spent time with them. We were able to get as many eggs as we needed, because the other thing, every family gets 2 eggs, so that if there's a sibling or somebody else, they also get an egg. And it was that they closed down. It became too expensive for them to do eggs. We were getting them, we were able to export them from the Dominican Republic for a short period of time into Haiti, and they didn't like the quality of the eggs. So the DR was actually sending poor quality eggs. We're working with an NGO that is doing an school-based egg intervention. And so we have to drive a little further than we were, but we are back to having a consistent egg supply, costing us more than we budgeted, but we are able to have a consistent supply. And the good thing is, they don't have to be refrigerated in Haiti. So because they don't process the eggs like we process the eggs. So they can last a little bit longer. Yeah.
Thank you for the great presentation. My question relates to the first one, but a bit different. When designing interventions, it's important to think about the cultural appropriateness and sustainability of a long period of time. DHA and APA are rich sources of omega-3. But if you engage the community, yes, it's very true. APA and DHA contribute a lot to brain development and have a lot of, value, more so to that period, 0 to 5 years. But when you engage the community, did they come out and suggest the egg? Is it something that they can afford to sustain? Because there are other rich sources like soya beans, seeds. Some seeds have a rich source of same. including fish oils and other forms of fish, which may be more affordable than the egg. So I'm looking at the cultural appropriateness and choice of the source of this omega-3, the DHA and the EPA,
Absolutely.
based on the community engagement.
And that is something that we struggle with, because animal source food is the best option nutritionally, but accessibility post-study can be a problem. And that, I will say, that is one of the things we're working with CRS on is a blended food strategy that is more accessible, less costly, and has, Laura is very adamant of the importance of it having what it needs to have to be nutritious for young kids. So it's not ideal, but we are looking at that in other ways, and talking to the Ministry of Health. Sustainability of eggs is an ongoing concern for us. Yeah.
Thank you very much. I have two concerns. One is exactly just looking at providing one egg a day for 6 months. I just wanted to know if at the time you were implementing that, you had a control group, and if the intervention was given to the control group after realizing the results after the 6 months. And
Go ahead.
the second one is looking at sustainability, because from what you read, there was a concern about sustainability, if you would be able to provide the eggs for the family. And this is just going back to the socioeconomic empowerment for the families or for the homesteads. And I'll just give an example of where I work, where we have children that come in with malnutrition. We might have the resources to provide the high energy milk to treat in the hospital, but then upon discharge, later the same child comes back, time back with malnutrition. That is because there's no empowerment there. So maybe we still need to look deeper into the socioeconomic empowerment so that the things we're treating do not return. Thank you.
And I will say, sort of separate from any funded study that we have going on, we do have a small pilot of a microeconomic intervention to help to see if that can help sustainability once the study ends. So we are looking at that, because they asked, first of all, they asked for it in the pilot, and it's not included in the large grant, but it was really important to us to respect that desire. And so it's another really small pilot that hopefully will be able to look at ways that we can sustain through philanthropic donations versus grant donations is where we're looking there. You had one other question there. Okay. Did I get both of your questions though? Oh, yes. So we do have a usual well baby care group that they're not getting the egg a day at the end, but they are getting a sort of a mini version of Grande Bien. Yes.
Right. Thank you very much for a good presentation. I just have a few concerns. When you're presenting about malnutrition or malnutrition being the exposure to stunted growth, we want to what did you find as the actual class of malnutrition? Was it overall malnutrition or specific ingredients were lacking in these children? And how did you measure to come up and say this is malnutrition, not other diseases that could have contributed to malnutrition. And then when you're talking about the interventions that you brought aboard, some of the interventions you said what you brought in the wash and the egg component. And you did mention on malabsorption and one of possible cause. How did you address this, the issue of malabsorption? As far as I would think malabsorption can be issues of worm infections.
Yeah.
How did you come to have that addressed? The previous speakers have put across the issue of eggs and the issue of sustainability, economic empowerment. I would think you would have also empowered these communities to grow food for themselves than really you were there and importing eggs. How many families can do egg importations? And vis-a-vis, if a mother or a family can't afford to buy a doll, something for a child to play with, will they afford to buy an egg in that context? Thank you.
Yeah, so that is certainly one of the challenges we have encountered is the sustainability of eggs. We are looking at a small study of a micro-empowerment economic intervention with a group of moms to see if they can, through that process, earn enough that they can sustain the eggs. We also, though, recognize that, and Dr. Iannotti loves eggs because they're so good nutritionally, but we are also exploring other possible alternatives that are more readily accessible and not nearly as expensive. Yeah. Okay. Yes. Okay. Okay.
Dr. Trish, thank you so much. I think we have so many questions. We could talk for more and more. Yeah. And you. Of course.
I know that, as social scientists and as people from developing countries, we have our donors who keep always telling us sustainability. Including me, I don't know what really it means. So in this context, do we mean sustainability in terms of the country being able to grow the eggs? You talked about the quota was bad, or is it sustainable? Are we talking about sustainability in terms of the parents being able to buy the eggs on the, So I think that we confuse these words and I'm not saying that it's a bad thing. Even me, I don't know sometimes what it means because as Fred, most of you in this room are not sustainable. We had to pay for your ticket to get here. So no, really, seriously. So so that's a fact, and you earn so well. So you would have said, Fred, don't pay for my ticket. I'm sustainable. I can come, present. And so I think that sometimes we just need to figure out and say, what is it that we mean when we talk about issues of sustainability? Do we mean this, the country being able to grow the eggs by themselves? Because, I would also think about issues of budget neutral. Is this budget neutral? Can they substitute porridge, the porridge that they give the students, to an egg so that it's budget neutral in that the government is already committed to giving each student lunch of some kind. In Uganda, they give what they call liquid lunch, and others is hard food, solid food. Can we substitute beans for an egg? Is it the same price? And that kind of stuff. Otherwise, I think we throw there the word without defining it, and we say, is it sustainable? And sometimes I ask people, what do you mean? Fred has Fred, I'm not sustainable. Because each time I'm going to Uganda, I reach into the NIH money, I buy the ticket. And I get to Uganda, I pay at the Sheraton using NIH money. So the question is, am I sustainable, my lifestyle? Probably not. So I think that when the donors start pushing you, ask the donors themselves, are you sustainable? Even this country, where we have capitalism at the highest level, the banks were bailed out by Barack Obama not long ago. So do we mean that capitalism is not sustainable? Because at some point it crashed. So anyway, I just want to leave it there. Maybe at some point we should discuss what do we mean by sustainability in behavior and social sciences, and do we really understand? Are we all on the same wavelength when we talk about issues of sustainability? That's all.
Thank you for a lively discussion. I wish I had a good joke about sustainability. I was trying to come up with one as I was walking to the podium, but I don't have one. So I'm going to go ahead and introduce Vice Provost Vijay Ramani, who's going to give us some concluding remarks for the day. Dr. Vijay Ramani, in addition to being an active researcher, is the Vice Provost for Graduate Education and International Affairs at Washington University in St. Louis. He holds the Roma B. and Raymond H. Witkoff Distinguished University Professorship and serves as a professor in the Department of Energy, Environmental, and Chemical Engineering. He serves as a key member of the Provost's core leadership team, advises the Provost on graduate education trends, programming, strategic planning, and policy, and works closely with school deans and vice deans to advance graduate and professional education across the university. He's responsible for administering several university-level fellowships and overseeing the Graduate Center. On the international affairs front, Dr. Vijay supports international research and education across all schools and facilitates global partnerships and programs. He serves as Executive Director of the McDonnell International Scholars Academy, leading efforts to recruit top scholars from around the globe to pursue graduate and professional degrees at WashU in preparation for careers as future global leaders. Please welcome Dr. Vijay.
Thank you so much, and good afternoon. I appreciate the introduction, and I'm really delighted to be here. I'll start off with some sustainability quips. You know, I'm a chemical engineer, and so we do a lot of work on life cycle assessment and sustainability. So, Dr. Fred, you can put me as a co-PI on your next grant, and as long as you cover my salary, I'll tell you all about sustainability. I got to say something. He talked about air tickets. I should say every year you have this wonderful conference in June in Uganda. And, you know, we try to do all we can to support Dr. Fred and his efforts. And in the past, I've asked him, would you like, so he always invites me to come. And I've always asked him, well, would you want me to come or would you like a check for $10,000 in lieu of my actually buying a ticket and buying a hotel room and everything? He's always picked the 10,000. Every time. Okay. So he understands sustainability. Yeah. So I have written evidence of this through emails, just in case he plans to deny it in the future. But anyways, look, I understand you've had a wonderful program today. And this morning, the Honorable Minister of Health for Uganda had given keynote remarks. Now, I had the good fortune of having lunch with the Honorable Minister and, hearing her vision, and, it's really inspirational. So delighted that she could be here. A great panel on collaborating partners who work with ICHAD to expand their impact in all the communities that they work in. We've heard from CHILD-GRF trainees who all presented their work and their accomplishments. Congratulations to all of you. And and keep up the good work. And in the afternoon, I believe you've had the pleasure to hear from very established investigators who have tested the impact of economic strengthening interventions using very rigorous methodologies in different populations across the globe. And last but not least, we had a great presentation that I had the privilege of also listening to from Dr. Patricia Cole. And she's highlighted her approach of an integrated nutrition, responsive parenting, and WASH intervention, and how that was implemented in Haiti amongst infants and their mothers. And now I think you mentioned that babies can't talk back, but you've evidently not met my daughter when she was a baby. She was pretty vehement in her responses. So one day, yeah. You know, Laura, I don't know if they had a chance to also see the eclipse. That's great, great spectacle. So fortunate that you are here, coincident with something which is quite rare. I believe the next one's not for another 15, 20 years or so. So hopefully you'll see you back then. Earlier as well, but definitely then, okay? You know, I'm going to try to wrap up. As we wrap up, you know, I think I want to share a few words about, you know, our international efforts and how ICHAD and Dr. Fred and all his colleagues' efforts here connect to it. We have very robust partnerships internationally. You know, we have a McDonald International Scholars Academy. It's a network of about 30 different university partners, of which Makerere University in Uganda is one of them. And through this academy, we recruit talented graduate students to our campus, to WashU, to pursue graduate studies, and these are fully funded. What I would love to do is to see many, many more students come in to WashU from Africa, from Uganda, from Ghana, from South Africa, from all the different places where we have networks, and we would like to build additional networks as well. So I'm very committed to doing that. And I should say that the work that ICHAD has done over the past decade or so, and I know last year was the 10th anniversary, wasn't it? So just entering the second decade, the number of applicants and students and the quality of students we've got from Uganda and Ghana have just been outstanding, and they've increased. And by the way, I'm not just saying, because I've met many of them. Many of them are in the academy, and I've had personal interactions with them, and I do mean that. And I think it's very difficult to overstate the impact that ICHAD has had in pushing this trend. And I'm looking forward to working with all colleagues at ICHAD to further increase the number of students as we try to diversify where our students come from. It's very important that, you know, we have a lot of great international graduate students, but it's very important that we have them sourced or have them come from various countries and not just concentrated or polarized in one or two countries or three countries across the world. And so I think for that, ICHAD and centers like ICHAD play a very pivotal role. So I just want to say, you know, in conclusion, I'd like to thank the Honorable Minister. I'd like to thank the Bishop of Masaka Diocese. Thank you, Reverend, for also being here. I know you just got here today after some travels, and we're delighted that you could be here with us. I'd like to thank Provost Beverly Wendland, Vice Provost Mary McKay, and Dean Dorian Traub, all of whom I believe have either been here today or will be joining this event in the coming days. And I really wish you all the very best. I wish you a wonderful day tomorrow, and look forward to catching up with all of you in the future as well. Thank you.
That concludes day one of our conference. So thanks everybody for being here. Thanks to all of our speakers. We're going to do pictures. So yeah, thank you everyone. Hope to see everyone tomorrow.